This is QD Clinic. Hi, I'm Jack Cush with Room Now. QD Clinic is brought to you by our campaign on psoriatic arthritis. Our case today is what to switch to after a TNF inhibitor. So this gentleman I've been taking care of for about 5 or 6 years. He's had longstanding psoriasis and then psoriatic arthritis that developed about 3 or 4 years ago. He's 48 years old. He really only has that past diverticulosis, nothing really else. Not diverticulitis, diverticulosis, and that's kind of important. His psoriasis was based on nail changes, skin psoriasis, oligoarticular disease involving the wrists and toes, and he had a previous motor vehicle accident. He's done really very well with a TNF inhibitor. It doesn't really matter which one. It has controlled his skin and his joints. But more recently, he has pain in his joints, mainly the MCP1 and CMC on one side, and he thinks that there's some swelling in those joints. When I examine him, I don't find any synovitis. I do find some enthesitis in a few spots. His skin is mildly active around the belly button. And so the question really is, in a case like this, if you stick it out, double the dose, manage this as an intercurrent flare. Maybe he's not compliant, and maybe you need to scare him into compliance by saying you can't switch or you can't skip doses here because it's convenient, because your skin's going to get worse, first, and then your joints are going to follow soon after. And so that's an important part here. We don't have a way of knowing what compliance is, and I think, for me, the best way is to ask them, what do you want to do? You want to stick with this drug, or do you want to switch to this other new drug that I think would be great for your skin and your joints? I think people who want to stick with the drug that they are on, that's dance with the one that brung you kind of thinking. People are adverse to change. They will either admit or not admit that they haven't been too compliant, and let's just double down and see what happens. So either they'll take it like they're supposed to take it, or you could, in the case of something like, etanercept, I give them a double dose for 3 weeks, or for adalimumab, I give them weekly adalimumab for like 4 weeks, and then have them come back in 6 weeks and see what goes on. But in general, I think this boils down to the loss of control. It's very, very clear that pretty much all the biologics, you average about a 10% loss per year. So that at 5 years, 50% of people will not be on that biologic. Now, it's always front-loaded, meaning it's more like 15 to 20% loss in the first year or two. And then after that, it averages out to about 5 to 8% loss. But it's on average 10% per year. And that's so your expectation that if you have someone on adalimumab or golimumab or whatever, that that half of them are going to have to be changing within 5 years. Which do I change to? It depends on whether the joints are the dominant issue or the skin. Joints are easier to control than skin. Joints you can change to another within the same class, or you can switch classes. I tend to be like a one TNF inhibitor and I move on, especially if they never responded to the TNF inhibitor. That's a primary non-response. You should never use a second TNF. If it's their second TNF inhibitor, I'm going to move on. I don't care what the data says. The data says that you can go to a second, maybe a third, if it's a secondary non-response or loss of response, or it's a loss of response due to toxicity. But if they have a toxicity with a TNF inhibitor, I'm not going to be playing in the TNF inhibitor class. If they have a toxicity in any class, I'm not going to continue to play within that class. So it really boils down to joints versus skin. I want to remind you, we just had a good journal club last night discussing the head-to-head trial of ixekizumab versus adalimumab. And you know what? The IL-17 inhibitors in PsA work just as well as the TNF inhibitors. Many of us have the belief that, I don't know about the IL-17s, IL-23s, maybe they're not as good at joints, but they're better at skin. That's not true. these head-to-head trials are proving that they are as good, they work as fast, and they work as well. So if I'm having a problem with the joints, I can use any of the drugs. Another TNF inhibitor, I could use a JAK inhibitor, I could use, whatever I can get away with, but I like going to IL-17s and or IL-23s. If it is a skin issue, meaning their skin is not being controlled, then I'm switching pretty much to either, IL-23, IL-12-23, or an IL-17. By name, that would be secukinumab, ixekizumab for IL-17s, ustekinumab for the 12-23, and guselkumab for the 23. Again, they're great at joints, but they're really, really good at skin. And I'm talking any skin, especially difficult skin, genital psoriasis, or recalcitrant scalp psoriasis, and then also palmar and pustular and plantar, especially pustular psoriasis. Those are going to need a better drug, and probably an IL-17-23. Maybe a JAK inhibitor for the palmar plantar disease, but there are just some studies out there that are starting to look at that. Hope you find this helpful. Tune in for more QD clinics on PsA.